This slide will help make clear why the CDC is saying that we have the worst drug epidemic in U.S. history. When they say that, they're referring to two prior epidemics. The heroin epidemic, which I mentioned earlier, that we experienced in the 1970s. And in the red box on the left, you see the height of deaths from heroin overdose in the mid-70s. And then we had a crack cocaine epidemic beginning in the late 80s, and you see that box on the right. Now, if you were to take the box on the left, the heroin box, and put that on top of the cocaine box and draw a line across all the way to the right, what you would see is that today we have significantly more overdose deaths than we had at the height of those two prior epidemics combined. And this slide is now a few years old. The CDC has just released data about a few weeks ago indicating that in 2010 there were close to 40,000 drug overdose deaths. So this problem is still getting worse. I was showing you in the previous slide all overdose deaths. What we're looking at on this slide is the breakdown by drug type. And what you can see here with demonstrated in red would be drug overdose deaths involving opioid analgesics. On the for heroin and cocaine deaths, the green and the blue line you see are much lower. We have significantly more opioid analgesic overdose deaths than heroin and cocaine combined. But we do see a disturbing trend developing, which is the gray line. And these would be drug overdose deaths involving benzodiazepines, drugs like Xanax, Valium, and Klonopin. And many of the opioid analgesic overdose deaths involve a combination of both opioids and benzodiazepines. So we have problems with overprescribing of not just opioid analgesics, but also benzodiazepines and certainly stimulants. Drug amphetamines are also being overprescribed. I think the next set of slides, and we're going to start early in the epidemic, are maps of the United States. And what we're going to be looking at here are the rates of people per 100,000 in a population seeking addiction treatment for addiction to painkillers. And what you see is that early in the epidemic, back in 1999, there were just a few states that were showing up in red or maroon, the states that were having the highest number of people per 100,000 in their population addicted to painkillers who were seeking treatment. I'd like you to watch what happens to the color of this map as we go forward in time. This is 1999. This is 2001. This is 2003. This is 2005. This is 2007. This is 2009. And what you can see is that in just about every state in the U.S., we've seen a significant increase in the prevalence of people with the disease of opioid addiction. And when you see a sharp increase in the prevalence of a disease over a short period of time, that is how one would define an epidemic. So what's caused this epidemic? Why are we seeing the maps turn red? Why are we seeing this sharp increase in overdose deaths and the increase in infants born with neonatal abstinence syndrome and the many other measures of this crisis? I think the best answer to that question came from the CDC. Len Palazzi, a medical director at the CDC in their injury prevention division, did something pretty interesting a few years ago. What he did to try and answer this question, he charted on this graph that we're looking at in orange the number of people dying of opioid analgesics, overdose deaths, over time. And then on the same graph in yellow, he plotted out sales for opioid analgesics. And what he argued in his paper is that this epidemic has been caused by a change in physician prescribing practices. That as physicians began to prescribe opioids more aggressively beginning in the late 90s, that increase in opioid prescribing is fueling or caused and is fueling this crisis. More recently, the CDC has released new data and to make the same point. And what you see on this graph in green would be consumption of opioids in the U.S. This is where you take all opioids, whether it's morphine or oxycodone or hydrocodone or fentanyl, and you convert it into an equivalent dose of morphine, and you plot out the consumption in the population. You see the sharp increase in green over time beginning in 1999 to the present. And something that's disturbing here is, I recall, I think it was back in 2007, that we first began hearing reports that the U.S. was consuming 80% of the entire world's opioid supply, despite having only about 4 or 5% of the world's population. That was back in 2006, 2007. Despite that, our opioid consumption, despite the fact that we were already consuming a disproportionate share of the world's opioid supply, it's still going up. And what the CDC is arguing is that as that green line has gone up, it's causing the red line, opioid analgesic overdose deaths, to rise, and causing the blue line, opioid addiction, as measured by people seeking treatment, to rise. This is clearly suggesting that the way to turn this epidemic around is to begin to reduce our overconsumption of opioid analgesics. So what caused this sharp change or this dramatic change in physician behavior? Why did physicians suddenly start prescribing opioids more aggressively than they ever had before? I think this slide, which shows you consumption of oxycodone in my state, in New York State, between 1980 and 2006, and I can tell you I've looked at more recent data, and if this graph were to continue to 2012, you'd see the line still going up. But here, what's nice about this slide is you're able to see the inflection point. You're able to see that the behavior begins to change in 1996, which is why I would also argue that that was the point at which the epidemic began. So you could look at this and you might ask, well, what happened in 1996 that may have caused this sharp change in physician behavior that caused physicians to suddenly feel much more comfortable prescribing opioids, to feel more comfortable prescribing opioids than they really ever had before. And I could tell you that oxycodone is the active ingredient in both Percocet. It's the active ingredient in OxyContin, which is an extended release form of oxycodone, and it also exists in an immediate release formulation. Here in the U.S., they're called Roxys on the street, which would be immediate release oxycodone, and I believe that product is also used in Canada. Well, 1996 was the year that Purdue Pharma introduced OxyContin. So one might look at this slide and say, well, maybe that increase is all attributable to a new product on the market that was being used that hadn't existed previously. But if you look at the next slide, which shows you consumption of hydrocodone, you see that there had been a slight increase. Hydrocodone or Vicodin, Norco and Lortab really weren't introduced until the 1980s. So prior to the 1980s, hydrocodone only existed in a cough syrup in the United States. So you do see a slight increase prior to 1996, but you also see that 1996 is the year that hydrocodone prescribing took off. And if I were to show you a graph for morphine or any other opioid, you would also see that 1996 was the year that the prescribing begins to take off. So again, the question can be asked, well, what happened in 1996 that led the medical community to become so comfortable prescribing opioids? I think the answer to that question came from a government report that was done in 2003 in the U.S. looking at the marketing practices of Purdue Pharma when they introduced OxyContin. And what you see here on this slide was what Purdue spent in marketing OxyContin or advertising OxyContin during the first 6 years of its release. And you see the comparison here is to other extended release opioids. So you're seeing the light gray bar, which is OxyContin, being compared to the darker gray bar, Duragesic, and the white bar, which is MS-Contin. And you could see that far more was spent in the marketing of OxyContin than it had ever been spent before in marketing of an extended release opioid analgesic. By year 5, Purdue was spending $30 million a year marketing OxyContin. But you could look at this and say, well, if that's the case, why didn't we only see an increase in OxyContin? Why do we also see hydrocodone increase and morphine increase and all the other opioids if this change in practice was all attributable to a Purdue Pharma marketing campaign? I think the answer to that question was also found in this report, where the authors of the report pointed out that the bulk of Purdue Pharma's marketing was unbranded, that Purdue didn't just promote their product OxyContin, but they really conducted a campaign to make physicians feel comfortable with opioids in general, not just OxyContin. And being that they were the company that had the brand product available, as physicians became comfortable prescribing opioids, they benefited disproportionately, but their campaigns were focused on using opioids more, not specifically using OxyContin. As you can see, the campaign by Purdue Pharma paid off quite well. By 2002, they were bringing in $1.5 billion on sales of OxyContin. So how did they manage to have such a successful campaign? Well, they were quite clever in their marketing. There was money spent on traditional drug advertising and sending sales reps into doctors' offices, and their campaigns were focused primarily on getting doctors to use opioids for chronic non-cancer pain. They were introducing OxyContin at a time when the medical community would not have prescribed an extended release opioid to patients. It would have been unusual for a primary care doctor to prescribe an extended release opioid to a patient with low back pain or chronic headaches or fibromyalgia. Back in '96, when they were introducing OxyContin, it was a time when the medical community would have been correctly concerned about getting patients addicted or concerned about tolerance developing to the analgesic effects that would limit the drug's ability to provide effective relief long term. The reason that Purdue was so effective was that they went beyond the traditional marketing, and instead they funded pain patient groups, and in some instances they created their own groups. For example, the American Pain Foundation, or another group was Partners Against Pain. These were groups that were meant to look like grassroots organizations advocating on behalf of pain patients, when in reality the term that I would use to describe them would be astroturf. They were artificial, meant to look like grassroots organizations. The American Purdue Pharma also worked with existing professional societies that were not astroturf, but had been involved in pain treatment. There was the American Academy of Pain Medicine and the American Pain Society and other professional organizations that received funds from Purdue Pharma to help them with a campaign to promote opioids for use in chronic non-cancer pain. Purdue also worked with the Joint Commission, which is an organization that regulates hospitals in the United States, and was able to get the Joint Commission to join a campaign making pain the fifth vital sign, so that in all settings, in hospitals regulated by the Joint Commission, patients would be screened for pain, and if they, usually the screening instrument involved smiley faces and frowny faces to indicate whether someone had pain. If a patient circled a frowny face and it was an outpatient, often that meant a referral to pain management, where a patient would likely there'd be a good chance the patient would be prescribed OxyContin. And then Purdue also funded organizations that worked with the Federation of State Medical Boards. This is the trade association for medical boards in the United States. These are boards that have as their mission the regulation or the protection of the public from doctors that might be prescribing in a reckless fashion. The Federation of State Medical Boards actually encouraged medical boards to let their physicians know that they would not be sanctioned for overprescribing of opioids, and that in fact they could be sanctioned for undertreatment of pain. And undertreatment of pain became code for underutilization of opioids. Now, all of these different organizations were accepting funds from industry to join into this campaign, but it was really more, I can't really say that all of these individuals and organizations involved in this broad campaign were being bought off by industry and promoting something they didn't believe in. I think many of the individuals and organizations who were promoting this campaign really did genuinely believe the messages, and the messages were that we were under-prescribing opioids because we were overly fearful of addiction, and there were medical experts telling them that patients didn't get addicted to opioids and that they didn't have to worry about addiction. So I think many of these organizations were profiting from their relationship with Purdue, but I think it was more complicated than saying they were doing this simply for money.